This 38-year-old woman has increasingly intractable right upper quadrant pain after cholecystectomy done 1 year earlier. LFTs and pancreatic enzymes have been normal and ducts are non-dilated, thus she's a type 3 possible SO dysfunction patient. Our first goal is to define pancreatic duct anatomy enough to see that manometry is possible. She has a small caliber straight pancreatic duct, so the aspirating triple lumen catheter is used to deeply cannulate the pancreatic duct. The catheter is continuously aspirated to prevent pancreatitis from overinfusion. Aspirated pancreatic manometry is clearly abnormal, with basal pressures well over the upper limit of normal of 40 in the top and the bottom leads. Thus, our indication is for pancreatic and biliary sphincterotomies, and we feel biliary manometry is irrelevant at this point. We next access the pancreatic duct with a 543 catheter and a 018 Roadrunner wire and place the wire to the tail in order to guarantee access. Now notice, interestingly, she has a separate biliary orifice, which is quite unusual in SOD patients. Because of that fact, we're going to go ahead and place a pancreatic stent first, here placing a 3 centimeter long 4 French soft single flange stent. The reason for such a short stent is she has a very small duct, and we prefer not to place longer stents in these patients due to fear of duct injury. Next, we're going to cannulate the bile duct next to the pancreatic stent using a 39 autotome 3.9 French tip papillotome. And normally this can be difficult to do with common channel, but because she has separate orifices, it's quite easy. You can see here a non-dilated bile duct. We're going to perform a wire-guided biliary sphincterotomy, proceeding very carefully in stepwise fashion because of the small size of the papilla and the small bile duct. And patients with small duct sphincter of Bode dysfunction are at increased risk of perforation from biliary sphincterotomy, probably because of the poor landmarks and often long, subtle, and tight sphincter. In any case, the biliary sphincterotomy is extended in a very careful stepwise fashion, trying to make it as complete as possible, as partial sphincterotomies probably have no benefit in terms of pain relief. And you can see here a nice, adequate, quite deep sphincterotomy. Because of that fact, we're going to do a post-sphincterotomy cholangiogram to assess quality of drainage and make sure there's no extravasation or perforation. And you can see here nice drainage of contrast with no leak. So we're satisfied with our biliary sphincterotomy. We're now going to move on to doing a pancreatic sphincterotomy with a needle knife over the pancreatic stent. And this is done by extending the needle knife, reaching in under the fibers but on top of the pancreatic stent, gently lifting and making short incisions. This is done again in a very careful stepwise fashion, and in this patient it's going to be a relatively limited sphincterotomy due to the very small size of her pancreatic duct and concern for scarring of the pancreatic duct itself from cautery injury if done too deep. You can see here we're getting in closer to actually see the extent of our incision and carefully extending it along the stent. Once we're satisfied with the incision, we'll stop and our job is done. We and many other specialized centers perform dual sphincterotomies at the first ERCP in SOD patients with abnormal pancreatic manometry who have frequent or intractable symptoms, based on a belief that response rates are better than for biliary sphincterotomy alone. However, this is a controversial procedure which really should be done only in specialized centers with a research interest or extensive experience in sphincter of Bode dysfunction. What's very important is to minimize risk of pancreatic duct injury, acute pancreatitis, and other complications. and hopefully there will be some long-term benefit in this patient, as we have found in about 60% of such patients who are not on daily narcotics. This pancreatic stent will remain in place for at least a few days, but must be either removed or documented to pass by X-ray within 2 weeks or so.